Hello, welcome again. We have been looking at yet another of yeah. We have been looking at yet another topic about so many series, and in this case, we are looking at the chest pattern radiograph, and like I was saying, it is very important that you systematically review the rest of all the aspect of the chest radiograph. And here I broke them into 4 or 5 parts. Here I mean the chest wall, the pleura, the hemidiaphragms, the mediastinum, and then the lungs. And you must make sure that at least you look at each one of them wherever you are going to interpret a radiograph. We have already reviewed the chest wall and what you look out for in the chest wall, the pleura, the hemidiaphragms. Now we are going to look at the mediastinum. In the mediastinum, like I said, it is important to take a good radiograph. Quality is paramount. In an expired view, it's going to distort the shape and the sizes. So it's important, it's in full inspiration, the patient is not rotated, and of course your KVs are very, very appropriate. In the mediastinum of importance, we look at any change in position. Sometimes the mediastinum may be changed to one side or the other, it may be deviated to one side or the other. The shapes may enlarge, and the sizes, of course, and either this may be general or focal. Possible causes and radiological features and differential diagnosis are always put into consideration, especially when one is thinking about the part of the mediastinum that is involved. We are looking at the anterior, middle, and the posterior, and of course the anatomy, the structures or normal organs found in these compartments may give us the differential diagnosis as to what could be causing the distortion. What am I talking about? I'm talking about a non-rotated image, a PA, or a lateral. It should be non-rotated. Now, if you rotate the patient, of course, it's going to affect the sizes and the shapes. Shown here on the screen are the features, anatomical features, which help us to know even the mildest of the distortions. Here I'm talking about the paraspinal lines, the paratracheal line, and the azygous recess, which I encourage you to evaluate lines like those, the paraesophageal, the paratracheal lines. We also talk about the cervicothoracic or thoracic abdominal sign, and these ones we shall become more clearer as we go on, that the clavicle is a good landmark. So if the mass is going above the clavicle, then we are saying that this is a positive thoracic cervical sign, and so the same with the abdomen. We also look out for what is called the hilum ovale sign. Hilum ovale sign is when you can see these hilar vessels behind the cardiac shadow, just like you can see here. Behind that lesion, you see those structures, so then it is positive. Angles formed with the lung effect on adjacent structures give us the possible differentials. Like I mentioned earlier, again, I said this mediastinum may be divided into 3 main compartments, and the structures there may give us the differential diagnosis. For example, in the anterior compartment, that is the anterior mediastinum, we usually suspect the lymphomas, the thyroid, the thymus, the thyroid, generally 3 T's. In the middle, this is where we find mainly the vessels, the cardiac, so we talk about the pericardiosis, the aortic aneurysm, and so on and so forth. In the posterior, because we have mainly the neurogenic tumor, the neuromaterial, the neurons and the nerves. So one would suspect a neurogenic tumor. So the location of the lesion may narrow down the differentials. Now, approaching the mediastinum, like I said, sometimes the mediastinum may be tracked to the area of involvement, and then we say there is loss of volume on that side, or it may be like in this image you see it is tracked to the left, so we suspect probably that the left lung has collapsed. This one again, lesion which shows beautifully there, it distorts the mediastinum. So in this case, we describe it as an enlargement of the mediastinum. Sorry about that. Yes, I was talking about this, and I was saying that yes, in this area, that lesion there has a positive silhouette sign with the mediastinum and the cervical overlay sign. So we suspect that this is in the middle mediastinum. So here we can describe it as enlargement of the mediastinum, lobular enlargement predominantly on the left. Okay, it affects a bit of the upper and the middle mediastinum, and then we describe it like that. On the other hand, we can get bilateral lobular enlargement of the mediastinum, and of course we can also say that it has a negative silhouette sign, and of course we can say probably it is in the posterior. This location, the CT scan has made this very easy, but still on a radiograph you can quickly tell where it lies. In this image, we see a positive thoracic cervical spine, cervical thoracic spine test is positive sign. The thoracic cervical spine sign is positive, whereby we have the lesion going above the clavicle. And once that happens, it helps us to locate the location. And in this case, the location is in the posterior mediastinum. Yes, on the lower row, again, we have lesions which can be due to a collapsed lung. Again, they may simulate lung atelectasis, may simulate a mediastinal tumor. But clear cut here also, we look at how it affects the trachea, and this also may tell us the lesion, and so on and so forth. So these are some of the examples: positive thoracic cervical spine, positive thoracic abdominal sign, and of course we also see a little bit of extension there. Now, these are the other examples which I always say, which I show that when the lesion has a negative silhouette sign, like we see in this image, then it is most likely to be posterior or anterior. So we need to do a lateral view and place it. In a nutshell, these are some of the conditions which we look out for wherever we are thinking about the mediastinum or we meet a mediastinum. The description is mainly with loss on the silhouette of the mediastinum, that is, to be enlarged focally or generally. Like in this case, it may enlarge generally, like we see in aneurysm. So when you are describing it, again, this gives you a hint. Many of these are never complete without a CT. So in this case, we can describe this one as there is gross mediastinal widening, predominantly on the right side, with positive silhouette sign and a positive hilum overlay sign. So this means that probably this lesion is in the anterior, in the middle mediastinum, because of the positive silhouette sign. And then of course middle mediastinum, these tumors or locations which are there can reduce on the differential diagnosis. Things are never complete nowadays without a CT scan, so this is a patient who would benefit from a CT scan. So, going on to the cardiac shadow, again, a lot of work has been done on the cardiac shadow, and most of the work now of the heart issues are handled with echocardiograms or even CT, echo, and all these. But still, the X-ray may be the first line where a hint is given as to what is happening to that cardiac shadow. Features of changing in position, shape, size are very important, and of course it can be specific chamber enlargement and possible causes. So it's very important that again you know the shapes of the cardiac shadow. Before we start, the anatomy is crucial. Someone must have taken a PA. We want to do a PA projection, because whenever we do an AP, then you're going to get the magnification. So if you are thinking about looking or studying the heart, ensure that it's a PA view and the patient is not rotated. Okay, patient is not rotated. And by that, then we can be able to comment confidently about the cardiac shadow sizes and shapes. In terms of anatomy, again to bring it on anatomy, we want to say that most of the anterior aspect of the heart is made up of the right ventricle. So when it enlarges, it is going to push the left ventricle upwards, and also the right atrium on the opposite side. So on the lateral side, lateral side, we have the right atrium, and posterior to the cardiac shadow, we have the left atrium. As shown on the lateral view, usually we have it again more systematic like that: right ventricle, left ventricle. So it's very important that we know what makes it quite quick. Now it's also important for us to notice that the cardiac size may be evaluated by using what is called a cardiothoracic ratio. Now, a cardiothoracic ratio, you measure the extent of the right heart and the left heart, and you add it to the extent of the right heart, and you divide it over the chest diameter, and of course A plus B over C is usually, the normal is 0.5. So we normally take 0.5 as a good marker. So anything more than 0.5, then it is enlarged. Yes, like in some of these, again you see gross cardiomegaly here. Of course, if you take the blue line, you add it on, you put it over there, you realize it's more than half. Okay, then you are able to say there is cardiomegaly. And of course, if it is overt, like we see, it's much easier, but sometimes it may be a specific heart chamber. If it is a specific heart chamber, then we look for features, like for example, specifically for the left atrium, because it is posterior in a chest radiograph, it tends to splay the carino angle. So we get splaying of the carino angle and that double shadow appearance, okay, again shown here. So that is seen in the left atrium. In the right ventricle, again the lifting off of the apex is very important, but on the left ventricle we have what is called a Shumau sign. Is this small animal here is called a Shumau, and it describes the apex displaced laterally and inferiorly, contrary to the left ventricle where it is displaced laterally and superiorly. Okay, then the right atrium, of course, usually the right side of the heart is bad. So in a nutshell, when you look at the cardiac shadow, this could give you a hint. But I must say that most of our patients come in late, so sometimes we don't get this, because when one chamber fails, it leads to failure of the other chamber and dilatation, and most of the time we get a globular heart. We get gross dilatation. So this is a patient who you want to send for a checkup, maybe an echocardiogram. We need to see an we do an echocardiogram. Other differential diagnoses which may mimic cardiomegaly is mediastinomas. We've already discussed the mediastinomas, but other features like a fat pad and aneurysm must be looked out for. What you're seeing may not necessarily be a cardiac condition, but may be a cardiac fat pad. And here a CT scan with the Hansfield units comes in handy. Echocardiography, of course, needless to say. So in a nutshell, that is the cardiac shadow. If I can just recap a few things here, and the most important of all is one, you must have a well-taken radiograph, non-rotated, full inspiration, and it must be a PA. And when the cardiothoracic ratio is more than 0.5, then you need to look at the heart carefully and see if it is a specific chamber enlargement or generalized cardiomegaly. The differential diagnosis may also be borne in mind. These patients usually benefit from echocardiography. The other aspect, the main aspect now which we are going to are the lungs, because usually we do the chest radiographs to look at the lungs. Yes, that is the main topic of the day. Now, change in position, size, it may be general focal, alveolar or interstitial, bilateral, all these may be looked at and may help us diagnose features like bronchopneumonia, TB, lobar pneumonias, and aspiration pneumonias. Okay, so if we can start with the unit cell of the lung. The unit cell of the lung is usually the alveoli. If you can imagine with me, the alveoli and the connective tissue. So the disease processes that can affect the lung can either involve the alveolar, in which we get what is called alveolar infiltrates or airspace infiltrates, and this pretty much is when the air is replaced with fluid or masses and it turns white. Normally, where air is on an X-ray, it appears dark, just like you see it here. But if this air is replaced by either fluid or mass, then it becomes white. So the whiteness is what is referred to as opacity. So then we start saying what type of opacity is it? Then we say it is alveolar phenotype, meaning it has replaced the air. Okay? And then, of course, the other one this is the silhouette sign. You have already mentioned the silhouette sign, and this is comparing that infiltrate or that opacity with the adjacent structures. Can you make them out? If you can't make them out, like you see here, then we say there is a silhouette sign. It can either be negative or positive, like in this case, excuse me, in this case it is a negative one where you can still see the cardiac shadow behind the main opacity. So this means that it is not in the same plane, and here it may be either posterior or anterior. But in a positive silhouette, then we know it is in the same plane. Back to the alveolar infiltration, just like that, I was saying the air is replaced with either fluid or masses, and then the place becomes white, opaque. So then we describe the opacities. Now, the distribution of these opacities again narrowed down the possible causative organisms, as we shall see. For example, the air bronchogram, which I have not mentioned, is this whereby you have the lucent lines crisscrossing through the opacity. So if you have those lucent lines, then these are referred to as air bronchogram. And the air bronchogram, presence of air bronchograms also suggest the infiltrate to be an alveolar. Here down is a normal radiograph, which you should know. It's better you put it in your mind, so that when you see the abnormal, you can quickly tell. Here again shows us a bit of the distribution. I mentioned earlier on that the distribution of these opacities narrow down the differentials. They narrow down the possible causative organs. For example, what do I mean? When these opacities, the alveolar opacities are confluencing, and they're mainly scattered like they are in these images, as you can see even here. Then we can say this is bronchopneumonia, okay? Because they may be confluent, but they are scattered. And if they are in the upper lobe and cavitating, then we can say this is cavitating bronchopneumonia, which we see in TB, okay, in the upper zones. On the other hand, if it affects a lobe, like you see in this image, then we say this is lobular or lobar or segmental or lobar pneumonia, affecting only one lobe, and so on and so forth. So if it is affecting scattered no sequence, then we can say bronchopneumonia. On the other hand, it may also describe what we call a bat swing, mainly affecting the mid zones and sparing the apices and the bases, a condition where we say it's a bat swing appearance and may be seen in pulmonary embolus. So, in a nutshell, the distribution tells us exactly what we are dealing with. If they are scattered all over the place, then we say this is bronchopneumonia. But if they are affecting a lobe, then we say this is most likely a lobular pneumonia. But in the appearance, then we say this is most likely going to be probably a pulmonary edema. Again, these are some of the examples of what we were looking at. We are saying if it is cavitating, confluencing in the upper zones, cavitating like this, then we say this is PTB. On the other hand, if it is still alveolar in the central zone, fairly sparing the apices and the bases, describing what we refer to as a bat swing, then probably we are talking about pulmonary edema. Now, pulmonary edema may be cardiogenic or non-cardiogenic. Again, we want to look at the cardiac shadow. Just like you see in this image here, you see that the cardiac shadow is relatively enlarged, and then we have the alveolar type of infiltration, centrally placed, fairly sparing the apices and the bases, and this is interstitial pulmonary edema. Here again, the distribution is due to that raise in the hemidiaphragm. Again, we see this is most likely a lobar pneumonia, B consolidation collapse there. So that is the alveolar type of pulmonary edema, and when we write a report, for example, if we were expected to write a report on that image, quickly you will say they are patchy alveolar infiltrates, confluent in a few areas, is confluent in the mid zones, fairly sparing the apices and the bases to demonstrate what is called a bat swing appearance. Rest are normal, so here we say alveolar pulmonary edema is likely, or bronchopneumonia with tendency to cavitate in a few areas, and then you can diagnose TB. So the distribution gives it away. Now, on the other hand, we may be talking about the interstitium, and the interstitium is what holds the alveolar in place. So the other time we are saying the alveolar being affected, and then we get the opacity, but this time if we have the connective tissue, we are talking about the bronchi, the bronchovascular markings, then we talk about the interstitial infiltrates, just like we see in this picture. Normally, the lung markings are seen faintly, like we see in this image, and we don't see them in the lateral chest wall. But if they become prominent, like we see here, then we are having interstitial pneumonitis or interstitial infiltrate, just like you see here. The bronchovascular markings become prominent, and they may extend to the lateral chest wall. Okay, so then we say there is diffuse prominence of the bronchovascular markings extending to the chest wall, and then we can conclude this is an interstitial type of infiltration or interstitial pneumonitis or pneumonia. The end stage usually is referred to when we have the cysts, many cysts, which lung is destroyed, and now we have what is called honeycombing, and this can also be a part of the whole spectrum of the disease processes, but this plumbage usually comes in towards the end stage. The whole lung is destroyed and replaced by cysts. It's also interstitial. And a CT scan can come in handy describing this bronchiectasis and honeycombing very, very clearly. So these are basically interstitial. As you can see, we don't have the air being replaced like we saw in the alveolar, and we don't have the positive silhouette or sign, and of course we don't have the air bronchogram. We only have prominence of the bronchovascular markings. Up here, these may be nodular, they may be linear, they may be mixed, and in some cases we may use terms like reticulo, nodular or reticulolinear infiltrates in our reports. So that in a nutshell covers our lung, and I have said that in the lung there are two main structures, that's the alveolar and the connective tissue, that is the interstitium. As one is looking at an X-ray, it's very important to appreciate that the alveolar is filled with air. When the air is replaced, then you have the whiteness or the opacity, and those are referred to as alveolar in nature, and the distribution gives it away. If it is distributed in a no clear pattern, then that could be a bronchopneumonia. If it is affecting a lobe, then that's a lobar pneumonia. If it is affecting maybe the mid zones, if it distributed peripherally, maybe then we can also diagnose COVID, which terrorized us a few years ago, so we can be able to diagnose it. So the distribution of the alveolar pattern gives away the disease process. On the other spectrum, then we talked about also the interstitial. Now the interstitial also has the distribution, but mainly these are the interstitial being affected, and these are mainly lines or dots, and then we talked about the end stage. So by and large, that is what I needed to talk about the lung. It's always good to continue practicing. When one gets an X-ray now, you look at it and you ask yourself, is this interstitial, is this pulmonary? But sometimes it may be mixed, and even if it is mixed type, still there is one of them which is predominating. So it is important that you describe it and you say this is predominating. For example, if you attempted to write a short report on this image, it's clear that basically we have linear or reticulolinear infiltrates, which are predominantly in the mid-zone, more marked on the right. Okay, and then here we can say this is an interstitial type of infiltration. The nodular one may be miliary tuberculosis, and of course we also reviewed the bronchiectasis. Good. Now the other aspect of the lung are the vessels, and the vessels may also be seen within it, and this will be our next topic. We shall look at the arteries, because when you look at the lungs, within the lungs you see there are the arteries and the veins. So then these arteries and the veins, their change in size and density may change on the appearances of the lung. We are talking about things like arterial and venous hypertension, pulmonary edema, and cardiogenic, non-cardiogenic pulmonary edema. Yeah, I think this is where we will start from in our next session, but this is what I had for you. Thank you very much.